Good afternoon, everyone, and welcome to our webinar, our chat show today, this afternoon, the 27th of November, 2021. I hope all of you are well and safe. Today, we'll be discussing diabetes and diabetes-related complications and the very exciting new development of SGLT2 inhibitors. I have with me here none other than Professor Diabetes herself, University Malaya Professor of Medicine, Dr. Chan Siew Pheng, to the extreme left, which probably needs no introduction to most of you here. And next to me, I have Dr. Jeyabalan Velayutham, who is my colleague in CVSKL, senior nephrologist, practicing there with us for the last 4 years. In fact, today is our 4th anniversary of the opening of CVSKL, and we are very, very happy, and this is part of our celebrations. I hope you find today's session informative and also enjoyable session. We will go through 3 different talks, and at the end of the talk, we'll have a question and answer session. I am Dr. Prof Chan. I'm a cardiologist in CVSKL. And to not delay things any longer, I think we'll start off the afternoons right away with a session on diabetes and diabetes-related renal complications, and this will be presented by none other than Dr. Jeyabalan. Jeyabalan, thanks.
Thank you very much. Do I talk? Hi, good evening, everyone. I'm going to be talking about microvascular complications in type 2 diabetes, in particular in relation to the kidneys, because that's my subspecialty. Diabetic kidney disease is the most important cause of kidney failure, chronic kidney failure in this country. 40% of our patients on dialysis are due to diabetes mellitus. Every year we get 1,000 people going on to new dialysis every year in this country. There's about 40,000 people on dialysis currently in this country. So the diabetic kidney disease is a very important illness, and it's important that we actually treat this condition at a very early stage before it becomes too advanced and it becomes more difficult to treat after that. So in the past, we have all been taught that diabetic kidney disease is a disease that is a slow progression that starts with protein leakage. We always assume that it was something that is caused by, initiated by microalbuminuria, which is small amounts of protein leaking, going on to macroalbuminuria, overt proteinuria, because of hyperfiltration at an early stage. And then subsequently, we have always been taught that slow progression, the serum creatinine goes up, the eGFR then goes up, and then only you get the decline in the function at a much later stage. However, recent epidemiological studies suggest there is actually no one-size-fits-all. There's a very different kind of presentation for these patients. So you can actually lose kidney function even without albuminuria. So urine can be normal and you can still lose GFR. So the proteinuria being the hallmark of diabetic kidney disease is now not really a truism by itself, especially in those who have a lot of vascular and interstitial pathology. You may not get much albuminuria. And on top of that, diabetic kidney disease is also more prone to patients with diabetes who develop acute kidney failure for various other reasons. For example, a patient with diabetes who develops a cardiac disease, heart failure, and develops acute kidney injury, they are more likely to then develop fibrosis and chronic kidney disease. So this is the previous classical staging for diabetic kidney disease. Stage 1 and 2 is basically classified as preclinical. It's due to functional and anatomical changes within the kidney, whereby there's an increase in the GFR, hyperplasia, mesangial hyperplasia, and at that point in time, no proteinuria or intermittent microalbuminuria. At this stage, the blood pressures are usually normal. So stage 3 is when the microalbuminuria becomes more persistent. This is the earliest stage we can actually detect clinically. At this point in time, some patients may develop mild hypertension. Again, the kidney function decline is usually too little to be identified because the serum creatinine is not a very sensitive indicator of early loss of kidney function. Stage 4 is overt proteinuria, macroalbuminuria. At this point, hypertension develops. There's further loss of eGFR, but again, not much that can be detected by our usual markers of kidney function. Stage 5 is when the serum creatinine goes up, when there's actually loss of eGFR. That's classically been considered to be stage 5. But like I said, nowadays we have recognized that not all patients go through this kind of stages. There are patients who go straight to losing GFR without much proteinuria. So previously we always said, okay, the patient comes with kidney failure, there's no proteinuria, it's not likely to be diabetic, it could be something else. It can still be true, but it can also have diabetic without much protein loss in the urine. So like I said, growing study shows that not all patients follow, these are basically for type 2 diabetes, follow this classification. So proteinuria doesn't always precede loss of glomerular function. In some patients, progression may occur without a transition to a period of microalbuminuria or proteinuria. So unlike what we were previously taught, so absence of microalbuminuria or proteinuria does not exclude diabetic kidney disease when the patient appears to be losing renal function. And most of these patients, the other thing that we have always been taught is a large percentage of patients who develop nephropathy, they also have retinopathy because both are underlying microvascular conditions, so they are always thought to be associated. Again, the non-proteinuric type of diabetic ketoacidosis have a lower association with retinopathy. So you don't have retinopathy, you don't have proteinuria, you don't have microalbuminuria, but just a rising eGFR can actually be a part of diabetic kidney disease. So so basically there are two main pathways for the pathology. This is the non-proteinuric pathway where the pathology is coming mainly from vascular and interstitial changes. So it's more of the blood vessels, the microvascular disease without much involvement of the glomerulus. So therefore, you do not get too much of proteinuria or microalbuminuria. The other, the classical pathway is where you get proteinuric because of mesangial hyperplasia within the glomerulus. Often, sometimes you have other forms of glomerulopathies also overlapping, and that leading to proteinuria and elevated serum creatinine. So the non-proteinuric and proteinuric pathway. Okay, this picture is a bit out of focus, but this is how a normal glomerulus looks like. You can see this nice looking capillary loops, all wide open, 1 cells per mesangial area, no cellular proliferation, no mesangial proliferation. Okay, and this is the classical Kimmel-Steele-Wilson nodules, which is what the hallmark of diabetic kidney disease, and also a marker of bad prognosis. So people biopsy which shows these nodules generally run a bad prognosis. You can see a lot of these capillary loops all can't be seen because of all these mesangial secretions and proliferation of cells. And this is the interstitial kind where there's a lot of ischemia causing a lot of interstitial infiltration and fibrosis because of the microvascular disease. So these kind of patients can present with raised creatinine, loss of kidney function without too much protein leakage because mainly an interstitial disease rather than a glomerular disease. Unlike the previous one, which is mainly a glomerular disorder where there's a lot of leaking coming in from the filters, the glomerulus. So in the 1970s, this is basically numbers from Europe. I don't think we are as good in Malaysia yet. In the 1970s, the time from diagnosis of diabetes, type 2 diabetes, to the onset of proteinuria was about 7 years. Now they have managed to push it up to 14 years. I do not think that's true in Malaysia yet, unfortunately. But the other thing is, we used to dismiss acute kidney injuries as one-off events that come and go. But nowadays, we recognize acute kidney injuries are important factors for the progression of CKD. Every time a patient gets an acute kidney failure for various reasons, drug-induced, cardiac failure, any other cause where the kidney suddenly deteriorates, even when they decline, when they recover, it leaves behind a lot of fibrosis and accelerates the progression of the underlying diabetic ketoacidosis. So in general, again, these numbers are from Europe. I hope we will do as well as Europe in the not so distant future. But roughly about 1/3 of patients they found will develop microalbuminuria within 10 to 15 years of diagnosis. And then another 10 years after that, 1/3 of those with microalbuminuria will develop end-stage renal failure. And once end-stage renal failure develops, only another 1/3 will be alive after another 5 years. So once your diabetic person develops end-stage kidney failure, on dialysis, renal replacement therapy, your 5-year survival rate is only about 30%, which is quite similar to many cancers. So that's why it's important to prevent patients going on to end-stage renal failure. So how do you recognize diabetic kidney disease? Unfortunately, most of the tests we are using are still quite primitive. Serum creatinine is classically still the most widely used, but the serum creatinine test is virtually useless at the early stage of kidney dysfunction. You need to lose about 50 to 60% of kidney function before the serum creatinine again goes out of normal range. So then that's why it's important to at least do eGFRs from the creatinine and not just depend on serum creatinine and normal ranges, because the normal ranges are not going to move until you've lost 50% of your function. So the eGFRs are better estimations of the renal function than serum creatinine. Cystatin C is also now widely available in Malaysia. It's also probably a bit more sensitive than the serum creatinine, more expensive though, but still at early stages, it's still not sensitive enough for our purposes to pick up early diabetic kidney disease, especially the non-proteinuric types. And of course, those who have proteinuria, the earliest stage we can detect will be microalbuminuria, for which we do an albumin-creatinine ratio, which is the detection of microalbuminuria. If the patient has already got proteins, overt proteins, your dipstick shows 2+, 3+, 4+ proteins, then you do not do an albumin-creatinine ratio, you do a urine protein-creatinine index, which is a measurement of protein leakage, because a person who's already got overt proteinuria, the ACR is going to be positive regardless. So if the patient has already developed proteinuria on your dipstick, then you want to quantify that. You either do a 24-hour protein collection, which is really tedious, or nowadays you can do a urine protein creatinine index, which is a spot urine test and gives you a fairly good approximation of the amount of protein loss. And now, since we are recognizing diabetic kidney disease without proteinuria and all the other classical features of diabetic kidney disease, there's even a point to consider early renal biopsies in patients with diabetes who are losing renal function without proteinuria or microalbuminuria. We should consider doing renal biopsies early because they may be actually diabetic kidney disease presenting with a non-proteinuria. So because of the inadequacies of all these our classical tests, there are different kinds of tests being developed to try to pick up diabetic kidney disease at an early stage so that we can intervene. So currently the two most promising biomarkers of disease, early disease, will be the tumor necrosis factor receptor 1 and 2, and there's also another molecule called kidney injury molecular 1. As far as I know, it's not available yet in Malaysia, but that will be a fairly useful test to pick up an early involvement of the kidneys by diabetes. So what do we do if you find the patient, somebody presents with diabetic and as evidence of kidney disease? How do we stop progression of diabetic kidney disease? So obviously, I think everyone is familiar, but the glycemic control, obviously you got to start there because if your sugar control is bad, then no matter what else, everything else you do is not going to work. We have got many patients who are on the best new latest medications for diabetic kidney disease, but the sugar HbA1c is 12% and proteins are leaking, and you know you're not going to get any benefit from these drugs in these patients. So the first thing is obviously we need to get the glycemic control. What level for diabetic kidney disease? It actually depends on the age of the patient, your comorbidities, as well as how long the patient has been diabetic. Generally, an initial target below 7% would be reasonable for many patients, but then looking at their characteristics, we may want to reduce it further, especially for younger patients without too many comorbidities. We try to go below, maybe perhaps as low as 6.5 or so. But we'll be a lot more cautious if the person is older, has got a lot of other factors like cardiovascular disease, etc. And also the level of education is important because they must be able to recognize symptoms of hypoglycemia and be able to know what to do if any such symptoms arise. So ideally, a ballpark figure of 7% will be our initial target for many patients. But we do try to bring it down lower, especially younger patients, new onset, not much complications. The lower it will seem to be a reasonable thing to do. Because we have enough studies that show certainly microvascular complications can be reduced by lowering HbA1cs. There's some controversy regarding macrovascular, which I think Dr. Lawrence may allude to later. But microvascular complications, certainly the better the sugar control, the lower the risk of progression of microvascular, which is basically a kidney disease, is mainly a microvascular complications. So however, like I said, the absolute risk of complications and the incremental benefits of intensively lowering HbA1cs must be balanced against the law of diminishing gains as well as the risk of hypoglycemia. So basically, you've got to find the target here. Okay, you don't want the HbA1c to be too high, you don't want to be too low. So that this level here is going to be different for different patients. An 80-year-old, we may even accept something like 7.5 or even 8 sometimes. Young patient, we most likely go to somewhere below 6.5. A young patient with no complication, educated patients, most of us will go to try to get it below 6.5 even, the HbA1c. So this is just one slide from the famous UK PDS study, which shows intensive control versus microvascular complications rates, the significant difference between intensive and the normal standard kind of control. This was one of the first studies that actually proved that good sugar control prevents microvascular complications. Even at the beginning part, it did not show much for macro, but I think when they extended the study, it shows even benefit for macrovascular complications. Okay, so basically, basically the UKPDS study showed that intensive glycemic control reduced microvascular complications, eye retinopathy, and microalbuminuria, and all cause of microvascular types of complications. So for microvascular complications, there's no doubt you try to go as low as you can in general. Okay, so virtually most studies all showed microvascular, sorry, that's a mistake. The VADT study did not show a reduction in microvascular complications, even though the glycemic control was intensified. But this shows that the difference was in UKPDS, the target group were all newly diagnosed diabetic, whereas the VADT people, the average duration diabetic was 11.5. So this actually shows the importance of intensive sugar control at an early stage. Because in UKPDS, they intensified the treatment for a group that was diagnosed at a much earlier stage of the illness. They showed the improvement in reducing microvascular, that's not macro, it's microvascular complication. Whereas the VADT trials, the average duration of diabetic was for 11.5 years, and you intensify control in that group, you don't get as much benefit as you're starting it early. So that's why it's important to be very aggressive in controlling sugar at the early stage of the illness, and when they are less likely to get complications from treatment also at that stage. So in addition to UKPDS, there's several other studies, basically all showing microvascular complications generally are reduced with better diabetic control. And I was just alluding to this UKPDS. When it first came out, they said there was not much difference for macrovascular, but I think when they looked at it further, it seems to show even macrovascular complications seem to be better with better control. What about blood pressure? Blood pressure is also important, but again, we have to be careful because our patients are all very varied, different age groups. So some older age groups may not tolerate very low blood pressure. Most studies for renal disease do indicate blood pressure control to be beneficial, especially in those with proteinuria. Okay? And the numbers given 120 to 125 is not a fixed number that we use for every patient. In older patients, we're a bit more careful. Those with a lot of cardiovascular disease and other stroke, etc., you may be more careful. But lowering blood pressure, especially in those with proteinuria, the studies are quite strong that lowering the blood pressure reduces microvascular complications. So many, because the problem is most of the studies looking at diabetes and blood pressure control in non-proteinuric patients have been looking more at cardiovascular outcomes than renal. So you find a lot of studies that shows good cardiovascular outcomes, not as much in renal, but there are studies that suggest we should control blood pressure in this group. So one of the studies that we did renal-wise for the MDRD studies in chronic kidney disease, these are not all diabetic patients, but basically blood pressure control was beneficial, especially when there's a lot of proteinuria. So, and the type of blood pressure medicines we are going to use, basically the ACE inhibitors and ARBs are our first line. This is the very first study that came out with captopril. This was with type 1 diabetes. Patients excreting more than half a gram of proteinuria, quite a bit of proteinuria, with a serum creatinine of less than 220. And this was the very first study that sort of showed that starting ACE inhibitor, in this case captopril, reduced that, end-stage renal failure, worsening renal function, and loss of renal function compared to a placebo or non-ACE inhibitor blood pressure medications. So this was the very first that set the ball rolling. And then the IDNT came out, we're using irbesartan. Again, there's a mistake here, it's more than 0.9 grams, quite a lot of proteinuria in these patients with quite advanced moderate CKD. And basically they compared irbesartan, amlodipine and placebo. They targeted the blood pressure to below 135 or 10% below the value at screening. Then at 2.6 years, irbesartan group, significantly lower loss of renal function, less people went on to dialysis, and this was independent of blood pressure control. And at the same time, the renal came. Renal was using losartan versus anything else except ACE inhibitors at that time. This thing. So again, these patients also had albuminuria, a bit less than the patients in the IDNT, slightly better renal function than the other group. But again, you had found significance in terms of patients going on to dialysis, worsening kidney function. But because they did not compare with, they used losartan versus any other blood pressure medications, so that they couldn't correct for the blood pressure so much with the renal. So basically, all these trials indicate ACE blockade decreases the risk of progression at every level of protein leak. However, till now, among the non-albuminuric diabetic kidney disease, we do not have major trials that have shown that an ACE inhibitor or ARB is going to make an extra difference compared to the standard hypertensive drugs in those who have no protein leakage, which is now being recognized as to be an important subgroup. Though we will still use ACE and ARBs anyway. Okay. So basically, ACE and ARBs remain our first choice. What about combination? ACE and ARBs is controversial. There's a higher risk of, it does reduce, there are studies that shows when you combine them, you reduce the proteinuria, but there's a higher risk of adverse reactions like hyperkalemia and acute kidney injury when you combine them both. So many people won't use. I do use it sometimes, but monitor them carefully. So example, this was this study on target where they compared telmisartan and ramipril alone, and there's significantly higher incidence of AKI in the combination group. SGLT inhibitors, the new kid on the block. Okay, I just talk a bit on the Credence trials where they use canagliflozin versus placebo. 4,000 patients diabetes. These patients with moderate CKD, 30 stage 2 to stage 3, stage 2, with quite a bit of protein leakage. And they must be on ACE inhibitors and angiotensin blockers already. So at 2.5 years, compared to placebo, starting the patient on SGLT, in this case canagliflozin, there was reduction in end-stage renal failure, worsening kidney function, and even the decline in the eGFR. Okay, even in those, when were recruited, their eGFR was more than 30, but lost it along the way before they were actually started the trial drugs. There was still benefit, in other words, for those below 30 mils per minute at initiation. Of course, heart failure, I won't talk to, Dr. Lawrence is here, and cardiovascular death. DAPA-CKD, this is the subgroup within the DAPA study. Here they actually used eGFR, which is far worse, 25 to 75, and more proteinuria. It's almost over nephrotic range proteinuria patients also using the dapagliflozin. And not all of them were diabetic. There are 2/3 of them were diabetic, while 1/3 were non-diabetics. And 98% of them were already on ACE and ARBs. And 2.4 years, there was significant difference in mortality, end-stage renal failure, and the decline in eGFR in this group. So, and the benefits were seen in both the diabetic and non-diabetic kidney disease. So it reinforces the notion that its effects were independent of glycemic control. EMPA-REG, the other famous trial with the SGLT, these are patients basically with high cardiovascular risk using empagliflozin. These patients had a slightly better kidney function than DAPA, but this amount of protein leakage was more spread out from mild to more severe protein leakage. Again, You can see worsening nephropathy, progression to macroalbuminuria, doubling of serum creatinine, eGFR decline were all significantly reduced in the SGLT group. Okay, I better go faster. The Vertis, ertugliflozin, these are among type 2 diabetic patients. Again, this was more of cardiovascular trial, but there was a subgroup analysis on the renal effects. Though there was no, it did not achieve statistical difference, but the doubling of serum creatinine was lower in the ertugliflozin group, and also lower reductions in eGFR or time to dialysis. GLP agonists, their main role is reducing proteinuria. They do not seem to have been proven to reduce progression so far. So you may want to add it to reduce proteinuria if you're worried on everything else and the patient is still having a lot of proteinuria, sugar is not controlled. We may want to consider one of these agents. Low protein diet is standard for us. So in summary, good individualized glycemic and blood pressure control is important. We have to avoid nephrotoxic drugs. If the patient has got protein leak, it's almost criminal not to start ACE or ARBs unless contraindicated. But nowadays, early introduction of SGLT2 inhibitors, if the patient has got concurrent CKD, the proteinuria persists despite ACE inhibitors. So it is now part and parcel of treatment of CKD now. And we consider GLP if the sugar is not controlled and patient has proteinuria. And of course, we need exercise, diet, and cholesterol control. I think that's the last slide. Thank you very much.
Thank you very much. Thank you very much. Thank you very much, Jaya. I can always count on you to give a very academic talk, and it was very, very interesting. And I can also always count on you to give some shocking sort of data. Like I was caught particularly with, I was a bit taken aback with that data that only one third of patients are alive upon diagnosis of end-stage renal failure. So that's very shocking, and it should shock us into greater action in terms of being aware of renal disease in the setting of diabetes, given that diabetes is now such a major epidemic in Malaysia. So we'll be taking questions at the end of the talk today, as I mentioned earlier. So our next speaker is none other than University of Malaya Honorary Professor of Medicine, Professor Siew Pheng, whose talk is about whether diabetes is just a matter of glycemic control or beyond that. I've always known that SP was, diabetes was only her launch pad to control the whole world of internal medicine. So over to you, SP. This is SP taking on the world.
Thank you very much, Lawrence, for that kind introduction. Right. Lawrence knows that I'm very controlling. I'd like to congratulate CVS on your 4th birthday, and also thank you very much for adopting me for today. So my role in this whole afternoon is, because you're talking about diabetes, you cannot have somebody without a glycemic slant. So appropriately, I'm going to try and wrest back SGLT2 from the kidney specialist and say, "Hoi, cardiologist, SGLT2 still belongs to the diabetologist." So is there a shift in how we manage our people and patients with diabetes? Well, let's consider the following points. First up, your patients all look different in size and shape, age, and things like that. So there's no way that you're going to have one size fit everybody. But what you do need to recognize in a person with diabetes is that you need to focus on a few facts. One, glucose control. And we use A1C as the surrogate to tell us whether the patient's glucose control is adequate, satisfactory, or not so. And then, how do we manage this for the best outcomes for our patients? And I like this little picture here, just to show you somebody that's bigger size than myself. Moving along again, just to remind everybody that in fact, when you have a person with diabetes in front of you, even though we are so excited about the data that you have just heard from Jeyabalan, and you're going to hear equally exciting data from Lawrence, that hey, A1C is still relevant. So why? I got data to show you. Here is an observational study long time ago from New Zealand, and they actually observed a massive number of diabetic individuals, 48,000 of them, and then they actually looked at their outcomes with regards to cardiovascular events and see that in fact, the higher the A1C, the poorer in terms of the higher the risk of cardiovascular events. You can see that. For every 1% increase in A1C, you've got a hazard ratio of 1.08, significant. So the higher the A1C, the higher the chance that you will develop a cardiovascular outcome. This is a data that you are so familiar with, but it still tells us a very important story. From the UK PDS, for every 1% reduction in A1C, you will reduce your chance of losing a foot by 43%. You will have the chance of reducing yourself from getting that terrible renal disease that Jeyabalan just spent time talking about. 37% reduction for every 1% A1C reduction. It's not you must get there, otherwise you won't get any kind of reduction in complication. 37% for every 1% improvement. So don't give up trying. You also reduce myocardial infarction and stroke by about 12 to 14%. Here is data that you may not be so familiar with, although I've left new here, is 2019 publication. This is from the Diabetes and Aging study. And they used the comparator A1C of 6.5 or lower. That means the comparison was those individuals with diabetes who had A1C below 6.5. And then all these columns belong to A1Cs that are higher than 6.5 at graded numbers, and this highest bar belongs to A1C above 9%. So if you actually improve glucose control down to 6.5%, you minimize your risk of having a microvascular outcome. But if you leave it uncontrolled, even within the first year, look at the number of microvascular complications can happen. So what do we learn from this? And that's the same for macrovascular events, same for death, Lawrence. Okay, so basically what are we learning from this? We learn that actually catch your patient early. Treat them to target as best as you can. Best is less than 6.5%. As early as possible, you want a legacy effect for these individuals. From the same diabetes and aging study, they were able to track these individuals for whether or not their glucose control was good from 0 to 1 years of diagnosis, or they left them poorly controlled up to 7 years. And so you can actually see here at the bottom of this slide, which again looks at A1C distribution. Those at this line will be 6.5% or lower. Here is 6.5 to 7, and at the top will be those whose A1C was higher than 9%. And you can see that if you leave them at worse control, you have a twofold higher chance of having a microvascular outcome versus, and this is at the first year here, okay? But if you leave them uncontrolled for 7 years, you massively increase the chance of a microvascular outcome by 6 times more. So this study tells us 2 things. Control them early and don't wait. And if you control them as best as you can. And then all of us are so excited about the cardiovascular outcome trials, right? You can all quote the EMPA-REG, you can all quote the LEADER trial and all these other trials, REWIND trial. They are all placed on this meta-analysis. And you can see this meta-analysis plots each of these trials onto how much difference between placebo and the active arm, A1C reduction. And you see that the best red-colored dots belong to the GLP-1 cardiovascular outcome trials, And the blue dots belong to the SGLT2 trials, and the green dots belong to the DPP4 outcome trials. And in this meta-analysis, regression analysis, they were able to show that in fact, they all fall along that line. If you, A1C actually accounts for a percentage of the improvement in MACE outcomes in this cardiovascular outcome trials. We recognize that there are certain things that some of these drugs do beyond glucose lowering, but glucose lowering also has an impact on these cardiovascular benefits that we saw in the cardiovascular outcome trials. Now let's move away. This is the next two slides are looking at all the trials in SGLT2, this first one, and all the trials in GLP-1, and looking at each of them in terms of their MACE outcomes. After all, these are all cardiovascular outcome trials, right? So here you have the SGLT2, the famous trials, EMPA-REG, CANVAS, DECLARE, VERTIS, CV. And they plotted the hazard ratio for MACE outcomes, and then when they actually did an overall meta-analysis, you can see that SGLT2s reduce MACE significantly by 10%. P-value significant. So when you place all the cardiovascular outcome trials together, you see a significant benefit that SGLT2s can give you a cardiovascular benefit. Moving along, now I've placed a table of GLP-1 receptor agonist cardiovascular outcome trials. And here we have a lot more trials, and you can see 1, 2, 3, 4, 5, 6, 7, right? A lot of GLP-1, and most of them fall on the good side of benefit, with only one that looks like it's just on neutrality. But again, when you overall sum them up, the GLP-1s show 14% reduction in cardiovascular MACE outcomes, significant. So these two classes of drugs have been proven to give us cardiovascular benefit, and that is the reason why we have now moved, and you're asking me the question about paradigm shifts, yeah? Moved away from blood sugar alone and focusing on just improving A1C, that we now want to in fact protect the target organ and try and use these two classes of drugs that gives us cardiovascular benefits, renal benefits beyond improving the glucose that we are seeing in our patients. So now moving back to my diabetic patient, your diabetic patient, how do I choose? That's a very commonly asked question. So what has come out in the algorithms is that we recognize many of our diabetic patients are bigger, all right, and that they have a significant amount of insulin resistance. And the only drug that works on insulin sensitivity is metformin. No matter how thin or fat you are, you still have insulin resistance that is contributing to that hyperglycemia. And as I said to you earlier on, that elevation in A1C is still something that you need to focus on. Metformin should be part and parcel of what you give your patients. But then the next question is, SP Chan, so what's next, right? What's next is, of course, the next layer will be tablets. You think the patient will say, "Aiyo, SP Chan, give me injection, give me anytime." I've never seen a patient like that, okay? So here we are, we have, you decide, do I go the sulfonylurea route, which is good old established drug, or do I go SGLT2 inhibitor route, or do I go DPP4 inhibitor route? Commonly asked, understandable, okay? And so now the recognition is, how does the data that I've just shown you shift the way we consider what next? And this is the latest Malaysian guideline that was launched just January this year, right? Where we recognize that we have to actually shift with the data and the evidence that we have seen. Not possible to actually turn a blind eye to this anymore. That although we recognize that A1C remains an important goal, we have to recognize some of these drugs give us, how would I say, target organ benefits beyond just improving glycemic control. So this is one of the algorithms that we have drawn up in the CPG, and I was part of the task force involved in this. So it looks a little bit complex, but let us just focus on these 4 columns, which includes, on the first right 3 hand columns is cardiac, belonging to those with ASCVD. ASCVD would be established cardiovascular disease, meaning sudah kena. But if you're not yet kena, but have high risk for cardiovascular disease, also belong here. Or you have heart failure, or you have diabetic kidney disease with or without renal impairment. And we recognize in the second layer, after metformin, you either choose a GLP-1 or an SGLT2, right? So in the second layer, it is either one or the other, all right? So it depends on your patients. I can't say, the best results, give us the best bang for the buck in terms of A1C reduction is this injection. Not many patients will accept that upfront. But anyway, we have shifted and we have recognized the data that is so strong that we cannot afford to skip it. So then, another commonly asked question. We have A, B, C, D, E. How do I choose which pill to choose for my patient, right? So let's just start with a patient. Because guys, you have heard and seen this so many times, you can regurgitate it to me. Let's start with this gentleman. He's 56 years old. A cartoon of him looks like this. So you recognize that he has diabetes for 2 years. He's already on the mixture of DPP-4 and metformin, full dose, plus glycoside, a sulfonylurea, and he weighs 92 kilograms. And he says, doc, I have been keeping to my diet and exercise since you scolded me 3 to 6 months ago, but not that much exercise because my knees are killing me. And with that, he comes back later, weight 92, jum, after MCO, Jeyabalan 94, all right? BMI 33, and this is what his A1C looks like. Look, if you are listening in, you'll be thinking to yourself, hey, if this were me, or if this were my father, or if this is my brother, what would I choose for his A1C? I hope you will agree with me, 56 is young, huh? Lawrence? Young, right? So let's hope that we will hear 6.5 or lower. So how now? He is about 1% above. So let's think. Do you want to do a SP Chan special? Knock him on the head, exercise some more, increase the dimicron glycoside because it's not full dose, start insulin, SGLT2, or stop the DPP-4 and start a GLP-1 because GLP-1 is more powerful. So what do you think the patient did? Okay, I already knocked him on the head 3 to 6 months ago. Didn't work, right? MCO was still hanging around. So here we are. Let me give you a bit more information on him. He doesn't have very powerful kidneys. His eGFR is 63. He has a significant, mild microalbuminuria. For the sake of Jeyabalan, let's say this was repeated, okay? So we started him like this. When I talked to him and said, look, your A1C is not looking any better. What should we do? So we decided, let's start on an additional medication. Don't wait, guys, don't wait, all right? So this was him. After that, not bad, Boleh tahan ka, Lawrence? Boleh ka? All right? So here we go. Another few more months, and that's what he did. So I suppose he was doing so well that, in fact, I was able to cut back on his glycoside, okay? So now, repeat, and his urine microalbumin had actually reduced to insignificant, non-positive results. Just to show you data to show that, in fact, you can combine DPP-4 together with SGLT2 in this Vertis factorial and get better bang for the buck in terms of percentage of individuals reaching A1C below 7%. So just to show you such a patient, all right? Now let's show you patient number 2, right? 72-year-old woman, 16 years of diabetes, don't have heart disease, doesn't need to visit Lawrence Chan yet. She exercises more than me, shy only, all right? And look at her weight. Her weight is 58 kg, also shy, me. because BMI is 24. So those of you think 23 should be where you aim for, oi, she's 72, okay, all right? 24 is fantastic. So she's on gliclazide 90, she's on Janumet or sitagliptin metformin, all right? And so she comes to me and she says, hey, doctor, my A1C look like this, okay? So this was 2-3 years ago, right? Where would you aim for, Lawrence, if she were to see you, all right? Would you aim for less than 7? Would you aim for less than 6.5? Or you think, oi, good enough lah, already bonus time, 72.
Oh.
All right, no way, Jose, I'm glad to hear that, okay? So if you say, no way, Jose, I don't think that's good enough, I want to drop her at least down to 7 or 7.5. If you say 7, 7.5, I can live with that, okay? So here we are, what would you add? Would you add an SGLT2? She's BMI 24, Would you add insulin? Or would you increase the sulfonylurea, the full dose, or metformin for the full dose? Let me disabuse you guys. Increasing your sulfonylurea and metformin won't get you very far. And I wouldn't give her basal insulin because her fasting glucose is already quite good. If you gave her basal insulin, she will get a hypo through the night. So I told her, you might need to go on injection for every time you eat. Because why do you think the A1C is high? It must be because the postprandial is going up. Right? Of course, she will say, if you give me injection, I will go and see my friend next door. All right? So here we are, we compromised, and I said, can I give you a tablet? We bargain. I give you for 3 months. If it works, you will live with it. If it doesn't work, maybe we really have to go the insulin way. So I have been very surprised. This is not the first patient that has improved with a normal looking body mass index. And she does lose a certain amount of weight. You have to warn them that they will lose weight. And in fact, you can see the A1C dropping to less than 7%. And her A1C, her fasting is starting to go to 4s. And in fact, I was able to cut down on her sulfonylurea. Please, guys, don't stop. You stop the sulfonylurea, your glucose will shoot up, all right? Because she was not well controlled in the first place. So every time you see them, ask them whether or not they have any hunger. Ask them whether they have any hypoglycemia. If they don't, then hold off. Don't stop the sulfonylurea. So fast forward to recently, I saw her. I have samples of these medicines given by various companies. She said, very expensive lah, dog. Okay. I said, I give you sample, can I? So eventually, I was able to give her the combination and then split the Janumet into the Sita plus ER2 combination plus metformin, and she's a very happy woman. So what did I want to, let me go back one slide. What did I want to emphasize here? These two patients look very similar, right? They were on triple oral therapy, not controlled. One was young, short duration of diabetes, but very big size. So SGLT2 would actually work well for that first case. This lady has long duration of diabetes. You think it may not work on her, but surprising, again, it does work on her, and I've been proven wrong, all right? So now this is case 3. I start with A, Okay, this is a 58-year-old man, Lawrence, somebody you would see. He has been no longer a virgin, right? He has had stent put in a proximal LAD because of a positive treadmill, okay? And he still has residual plaques. And he's been frightened already. So he has had, almost die one time already. He said, okay, today I'm going to change my life. And over the last year, he has improved his lifestyle. He has reduced weight. He has become slimmer than his doctor, all right? And then his recent assessment for cardiac has been really good. But let's say his A1C looks like this. What A1C would you want for him? Let's hope you will agree that you want less than 7%. So that means he's about 1.7% above target, yeah? So what do I want to teach you here? Is there an indication for SGLT2? Definitely, because he's got cardiovascular disease. Does he have an indication to give a combo upfront? Definitely, because he's so far above target. You add one and then after they try another one, the patient may be a little bit demoralized after they still don't get where they need to be. So this would be an ideal patient for a combination DPP-4 SGLT2 up front, okay? But let me show you, this is case 3B, and I want to give a shout out to Lawrence and our good friend, Dr. Kannan. This is his actual patient. It's not a made-up patient. This is actually what happened. He was stented, and then this patient went on this fantastic diet and lifestyle, and he looks like this now. This patient is at target already, right? My question, which I will know you guys are thinking, will you stop his metformin? Please don't, all right? Is there a definite indication to add SGLT2? Yes or no? Absolutely yes. Whatever you see, the algorithms that you see from the ADA, ESD talks about somebody like this, where the A1C is well controlled. Do you still add SGLT2 for the cardiac protection? Yes. But the next question that I commonly get asked is, will I stop his metformin? I won't stop his metformin because these two drugs are very safe. Please add it on top. Again, just to tell you where this patient sits, established, kena already, add the SGLT2, please. So, Lawrence, I hope I've kept you awake on this Saturday afternoon, all right? We are very lucky that we have drugs that in fact work on all the parameters to improve glucose control. So we have drugs that will reduce glucose, help us reduce weight, reduce blood pressure with a low risk of hypoglycemia, such as SGLT2s. You've heard from Jeyabalan, all right? They protect the kidney. We are going to see more data from Lawrence that it will protect the heart, right? And then it is safe in the elderly. So what more you want, all right? So when you're asking, are we seeing a paradigm shift? Sudah datang lah, it's arrived. But remember, I'm a diabetologist at heart. Please don't forget the A1C. You want to have drugs that improve glucose without, if the patient is overweight, to get the patient to lose weight without causing hypoglycemia. Protect every damn thing you can protect, all right? And then reduce the patient from having another heart attack. So I celebrate. The last 5-6 years have been very, very exciting for diabetologists. So the common question I'm asked by cardiologists, do you treat to benefit the target organ or do you treat to target A1C? Let's do both. Let's not fight. Thank you very much, Lawrence, for having me this afternoon.
Thank you very much, SP. As usual, you teach while entertaining. In your previous life, you must have been one of those kiddie show hosts that entertain the kids and teach them a lot as well. It was the most informative talk. And as you said, it is a special moment now. In many ways, I feel that through my career, where at the beginning of my medical career, that was when the statins came in. And that was a huge, huge impact in the world of cardiology. And now in the twilight of my career, we are seeing another very interesting moment where we are going to see a huge shift that will be very impactful with the arrival of the newer anti-diabetic agents, which had such a huge impact on not only cardiac issues, but also, kidney disease in diabetics as well. As I said, we will be taking questions, especially for Professor Chan, who will answer any question on diabetes except one. I think the Malaysian CPG guidelines should include how to, in the algorithm, how to get an appointment with a diabetes specialist, because I think that is the biggest problem for the legacy effect in Malaysia. I hope the Malaysian Diabetes Society hears this, because the biggest obstacle to achieving a low HbA1c is getting an appointment. So without further ado, so I'll go on to the next session. So thank you very much for joining in. Actually, in preparing this talk, I was going through the data, and the data is really, really exciting. We have some new agents around, and today I'm going to talk about the SGLT2 and heart protection. A few days ago, incidentally, a patient of mine walked in and said, "Doc, I hear there's a magic drug, you know, and this drug can reduce heart disease, and I really should be on it." And I said, "What are you talking about?" Then he said, "Oh, this drug is called such and such." And I said, "Oh, you're already on it." Fortunately, he was already on the magic drug. So you may, doctors, you may come across patients who are now online a lot of the time, and they may want to know about this magic agents, and I hope I can brief you, give you some information on it as regards heart, SGLT2s and heart protection. So SGLT2, they work here, right? And they inhibit the reabsorption of glucose, and also while we have got this graphic on board, they also inhibit sodium reabsorption in the proximal tubule of the nephron. So I better not say too much because Jeyabalan is by my side, so I better not elaborate too much beyond this. Now, where does this story of SGLT2 begin? It begins in 2015 during the EMPA-REG outcome trial announcement. This trial was designed to meet FDA requirements. It's a requirement now for all diabetes drugs to show that they are not detrimental to the heart. But instead, it stunned both the diabetes and cardiology community because this drug, in this case, empagliflozin, showed cardiovascular benefits. Not only was it neutral, it showed benefits. So the outline of my talk is going to be about SGLT2, where it was developed as an anti-diabetic agent, but more and more, the beneficial effects on the cardiovascular system is now very obvious. And these beneficial effects seem to be independent of glycemic control. That means independent of the A1C SP, so you may have to explain this. I will be elaborating a little bit about trials, but I won't be going too much into details. It is Saturday afternoon after all. And I will maybe talk a little bit about possible mechanisms that explain the cardiovascular benefits that are beyond the benefit of controlling the HbA1c. Again, SP, we may have a debate coming up. We may have to come to blows over this. And because of the results of the SGLT2 trials, the SGLT2 agents are now have entered into guidelines, which we will talk a little bit more about, and the guidelines even extend to the use of these agents in non-diabetic patients, which is a very, very exciting development. So this is a huge paradigm shift. This is the Sputnik moment for us in the year 2021. So just to conclude the beginning of my talk, I want to allude to one thing here, a meta-analysis of 4 large clinical trials with more than 24,000 patients reported that the use of a widely used agent in type 2 diabetes was actually associated with a 27% increase in all-cause mortality and a 23% increase in hospitalization for heart failure. We will come back to X at the end of this talk. So here are the trials. There are 8 trials mentioned down here, and please note, they are all to the left of the forest plot line in terms of cardiovascular benefits, in terms of macrovascular adverse reactions, and hospitalization for heart failure. So let's just, what is important from the previous slide is that across all the whole patient population, whether with type 2 diabetes or without, all these trials of SGLT2 agents demonstrated CV cardiovascular benefits. So cardiologists are grabbing the SGLT2 for themselves away from the diabetes and endocrine doctors. Now, most notable is the reduction in the risk of hospitalization for heart failure. And also the trials, as I said, they indicate that there is a dose relationship between the dose of an SGLT2 and the A1C reduction, right? However, there doesn't seem to be such a relationship when it comes to heart protection. Therefore, there must be mechanisms other than glycemic control, although, of course, I must show due respect to my professor here, that the A1C is, of course, no doubt, but I think there might be something beyond A1C control. And all these trials also show that there is improvement in patients without diabetes, but with heart failure alone. And also that not only you improve their outlook, you reduce their hospitalization rate, but you also improve quality of life based on scores such as the Kansas City Cardiomyopathy Questionnaire scores. So let's just look at one trial to start off with, the EMPA-REG trial, 2015, 7,000 patients with type 2 diabetes and cardiovascular disease. Now, just a quick history thing here. Why was this trial required? Because only in 2003 with the UK PDS trial did it show that metformin showed some benefit. However, in 2003 with the pioglitazone trial, there was, instead of a benefit, there was actually a shocking increase in hospitalization for heart failure to the order of 41%. Beyond the pioglitazone trial, the US FDA made it a requirement for all future cardiac anti-diabetic drugs to show that they were beneficial or they were non-detrimental as far as cardiovascular outcomes was concerned. Therefore, all new diabetes drug agents, anti-diabetes agents had to show a cardiovascular safety trial. So this trial was announced in 2015, and it showed that with the combined primary endpoint of cardiovascular mortality, non-fatal myocardial infarction, and non-fatal stroke, there was a beneficial effect. Also, when you included what we mentioned before with unstable angina hospitalization, there was a 2% reduction. There was a reduction in all-cause mortality. There was a reduction in cardiovascular mortality. And most importantly and most markedly, there was a reduction in heart failure hospitalization. Because remember, pioglitazone showed an increase in heart failure hospitalization. So what it showed was that empagliflozin, which was the agent here, as compared to placebo, decreased the risk of major adverse cardiovascular events, MACE rates, and the effect was attributed to a significant reduction of risk of death from cardiovascular causes. The risk of hospitalization for heart failure and the risk of death from any cause was also not only decreased, it was markedly reduced by the treatment with empagliflozin. Now, there was a marked correlation between the dose of the drug and the drop in HbA1c, but the two different dose groups, which is the 10 milligram and the 25 milligrams, did not show a similar decrease in risk. That means the higher dosing did not decrease heart failure much more, which implies that, again, there was a mechanism other than glycemic control in preventing cardiovascular deaths. And this we are going to talk about a little bit later to see what might be the reasons behind it. So then they moved on to the EMPEROR-reduced trial, which is about 4,000 patients, which looked at patients with heart failure with reduced ejection fraction below 40% and with NYHA functional class 2 to 4. And this reduced the composite risk of hospitalization for heart failure or death from cardiovascular disease by a significant amount, 19.4 versus 24.7, and also improve quality of life scores. So the effect was similar whether there was diabetes or no diabetes. Okay, again, emphasizing the same point over and over again. Another trial which I want to talk about briefly is the DECLARE-TIMI trial, which was for type 2 diabetes with an atherosclerotic cardiovascular disease or a high risk thereof. It showed a marked reduction in hospitalization for heart failure, but it did not reach significant statistical significance for the reduction of death from any cause. This might possibly be because up to 60% of the patients were not actually patients with ASCVD at the time of enrollment. So they were a relatively lower cardiac risk group compared to the emperor-reduced group. And another trial is dapagliflozin trial in heart failure, and it involved patients very similar to the emperor-reduced trial, and again, it showed very similar data of reducing all-cause mortality, reducing the composite, the risk of death from cardiovascular disease, and reducing hospitalization for heart failure. Now, there is a meta-analysis of the two trials, the emperor-reduced and the DAPA-HF trials, because they are relatively similar groups. So the pool number of patients is 8,000, about 8,500 patients. It showed a 13% reduction in all-cause death, the 14% reduction in cardiovascular death, and importantly, a 26% reduction in combined cardiovascular death or first hospitalization for heart failure, and 25% decrease in the composite of recurrent hospitalizations for heart failure. So, again and again, you will see that all the SGLT2 trials show about between a 25 to 35% reduction in hospitalization for heart failure. It shows, again, a reduction in cardiovascular deaths. So please commit this image to your memory. No, I'm only kidding. This just something to, a graphic to look at what we are going to talk about next, which are possible mechanisms of why we have, what's the magic that these agents are creating. So, what are the potential mechanisms of SGLT2 inhibitors as far as cardiovascular protection is concerned? One could be the attenuation of glucotoxicity. I tell you, it's quite a mouthful. This is the graph. I never knew there were such agents, but the world is moving along this way. We have to know about AGEs and RAGEs. So, what are AGEs? AGEs are advanced glycation end products. So, and RAGEs are receptors thereof. So, what are AGEs? AGEs are compounds that are proteins, lipids, and nucleic acids that have been glycated and oxidated. So, as you said, you don't want oxidized things, you don't want glycated things, and RAGEs are the receptors thereof, and they are present on cardiovascular cells such as smooth muscle cells, endothelial cells, cardiomyocytes. So what happens? AGEs then mediate their effect, their detrimental effect, by cross-linking tissues. I think this goes right back to medical school, and this bottom line is these agents are more in the setting of poor diabetes control, and they contribute to increased vascular stiffness and myocardial fibrosis, right? And these have been corroborated. It's not something we just made up. They have been seen in primary studies in diabetic rats. And suppression with SGLT2 does show benefits on the kidneys and aortic tissues. So that is one possible, there's one mechanism by which the SGLT2 works. Another one which may be more more accessible to us who are not so in primary medical and physiological science is the natriuresis and diuresis brought on by SGLT2 and how they benefit in heart failure. So SGLT2 reduces the reabsorption of glucose in the proximal tubules. They also at the same time reduce the reabsorption of sodium in the proximal tubules. So what does that lead to? It leads to natriuresis and at the same time osmotic diuresis. And they also block sodium hydrogen exchanger number 3, which mediates sodium reabsorption also in the proximal tubule. This one, we may have thrown this back to Dr. Jeyabalan, who will then pull up his kidney and show us where this exchanger is. Now, interestingly, skin sodium levels, so our diabetics will have a high, they're not only sweet, they are also salty. Skin sodium levels are associated with greater left ventricular mass, and they are increased in diabetics. So your diabetics are sweet and salty. So SGLT2 reduces skin sodium levels in type 2 patients. So you have a natriuresis, and the natriuresis, you know, we are always asking patients to reduce salt and to reduce salt. This is one mechanism by which it's an obvious mechanism by which SGLT2 can lead to benefits in heart failure, because we need to have a lower sodium level in heart failure. So what does it have? What does it mediate? The SGLT2 will then lead to a rapid increase in urine volume, about 110 to 470 mils per day. So when you start somebody on SGLT2, I always tell them, just be careful, you'll pass a lot more urine initially, and then it will stabilize. However, there will be a persistent decline in plasma volume. So this is very, very interesting, of 7%. This is something we need to achieve in patients with heart failure. So SGLT2, by getting rid of salt and water, therefore attenuates congestion. However, it attenuates congestion with little effect on the arterial perfusion. Now, how is that actually possible? So we go to a mathematical model. I can only tell you this briefly, but really, it's really exciting reading, and it's almost like, you know, this is more interesting than those video games that people play. This is a mad scientist kind of interesting thing. Mathematical model suggests that there's what they call an osmotic diuresis that creates greater clearance of water from the intercellular space than in the blood vessels. I mean, that is like incredible, right? If that's absolutely true, that means you maintain your vascular volume and you get rid of the water that's in the lung and in the legs, you know? So you actually maintain, and if you maintain the volume in the blood vessels, it's less detrimental to the kidneys, which is the problem we've been having with the usual diuretics we've been using. It is really this is really interesting, and as I said, this is where the big, huge paradigm shift is coming. So this mechanism is what may underlie the reduce heart failure, reduce hospitalization for heart failure, and improve quality of life. You are able to maintain the volume in the vascular space while reducing the congestion in the intercellular space. And the next mechanism that helps in preventing heart failure would be the reduction in blood pressure. So when you start a patient on SGLT2, you know you must tell them you might be a bit giddy. You know, I always warn them. So the reduction doesn't seem to be so huge here, because the meta-analysis says 3 to 4, although clinically sometimes I see a much bigger reduction in blood pressure. And this reduction in blood pressure persists. Now, the next sentence, I almost find it very hard to believe. You said the decrease in blood pressure is greater during the daytime, you know. So that is when people are moving around, and that's when blood pressure shoots up, and that's when people can get into more trouble. So this effect, we don't know exactly why. It may be, again, attributed to this thing called the osmotic diuresis and natriuresis, but the SGLT2 may also influence the sympathetic nervous system. In short, really magical. So the antihypertensive effect remains unchanged, right, regardless of the dose of the SGLT2. Again, relating to other than diabetes control as a mechanism, right? So the SGLT2 reduces plasma volume, as I mentioned, blood pressure, but heart rate is not changed, right? You would expect that if you reduce the volume, reduce fluid, the heart rate may shoot up, but it may be because it reduces preload and afterload, and it may inhibit the sympathetic nervous system, and this may be beneficial. There are multiple other mechanisms mentioned in different studies, such as improvement in cardiac energy metabolism. Now, this is also a basic science, which will be a bit too heavy for a Saturday evening. Amelioration of endothelial dysfunction and vascular stiffness, we talked about already. Weight loss, we know that weight loss helps heart failure, and weight loss we have already seen is about 4 kg weight loss in a lot of these patients. Protection of renal function, what more proof do you want? Because Jeyabalan has already shown us that. Then it may also mediate through a reduction in serum uric acid levels. There may be improvement in cardiac structure and function, and attenuation, inflammation as well, like everything, it affects everything. So the agents are a powerful agent. There's much to be learned. It is a relatively new group of agents, but the effects seem to be really quite groundbreaking and quite something that will change us in the field of cardiology and in diabetes. So coming to the end of this, I just want to say that just mention a few things. In the past, the anti-hyperglycemic agents have been shown to reduce ischemic microvascular events, but some of them may have even worsened diabetes, cardiomyopathy, and heart failure. Sodium glucose cotransporter 2 inhibitors, SGLT2. This is a novel class of glucose-lowering agents that consistently 26 to 35% reduction in heart failure hospitalization, unlike all other previous groups. Now, canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin have been approved for patients with both type 2 diabetes and cardiovascular disease. In May of 2020, dapagliflozin was approved for FDA for use in patients with heart failure and reduced ejection fraction. So your heart failure patients, even those without diabetes. In August of 2020, dapagliflozin and empagliflozin were recommended for the treatment of chronic heart failure with reduced ejection fraction in the ESC guidelines. This is for the patients who are just with heart failure, but without diabetes. Coming back to the beginning of our story, again, a meta-analysis of 4 large clinical trials, more than 24,000 patients, reported that the use of X in type 2 diabetes was associated with an increase in all-cause mortality and 23% in hospitalization on heart failure. Unfortunately, X is insulin. So it's just, we cannot abandon insulin at this point. We have to, this is just food for thought, food for discussion, it's just time at this juncture in 2021, we really have to have a huge rethink about how we approach treatment of diabetes. With that, I think that is my talk for today, and then we will be taking questions. I think we will be taking questions through the internet, so please key in your questions and we will try to answer your questions. Thank you very much. Oh, thanks. So thank you for joining us again. And first, before we carry on, I want to thank Dr. Jeyabalan for his very academic and shocking talk, and Professor S.V. Chan for her very entertaining but very educational talk. And I hope you found the information we provided useful. And we really do think that things are shifting dramatically, and it's a very interesting time in diabetes and diabetes and kidney failure and diabetes and cardiac disease. So we are already getting questions coming in. So we have about 20 minutes to run through a series of questions. So keep them coming. Question number 1 goes to Jeyabalan. Can a dialysis patient use Ozempic?
No. the GLP,
Yeah.
GLP agonist. Currently, I think the lowest you can go is 15 mils EGFR. So anybody less than that. So dialysis patients currently can't. We don't use.
Do you make dose adjustments for according to EGFR?
Sorry?
For Ozempic? For
Semaglutide.
semaglutide, yes,
Okay.
sorry. For semaglutide, do you make dose adjustments according to the renal function?
No, not that I'm aware of.
So it's either on and then not for dialysis
Not
patients.
for dialysis patients.
Thank you very much. Question number 2.
Maybe we can advance from there. The question should be also SGLT2s. Can you use it in patients on dialysis? I think that's just as important, more so. Jaya?
Yeah, so I think the lowest we've gone down, if you look at the DAPA, they've gone down to about 25 mils per minute GFR, which is stage 4. So anything below that is currently not advisable.
So in fact, for me, for cardiologist, I want to know what I can use in renal failure. What are the diabetes drugs that we still can use in patients who are in renal failure?
Okay. Basically, insulin, you know, the best one. Safest. Metformin we can't use unless it's not too bad renal function. Sulfonylureas, you can still use sulfonylureas carefully, make sure they don't go hypoglycemias. The DPP-4s also, if with dose reduction, can be used.
Do you use a DPP-4 in renal failure, in patients on dialysis?
On dialysis, it can be used, but I personally don't find that very useful.
Yes.
You know, it's actually easier to switch to insulin.
Insulin. Yeah.
Perhaps I usually tell my patients, if you want your diabetes to get better, get renal failure. Because a subset of patients who develop renal failure, their diabetes goes away. They don't need any medication to control their diabetes. While there's another subset where the glucose remains difficult to control, and those individuals, insulin will be the best answer for them. In some patients where the glucose still remains a little bit high, sometimes DPP-4s, but they are the patients that I see that are kind of like just pre-dialysis. Those who are kena dialysis already, Jeyabalan takes over, and I don't see them anymore. But usually you find that the diabetes goes away and the sugars are easy to control just on diet alone. So sometimes I threaten my patient that way.
In fact, to follow on Prof Chan's statement there, so I think if you have a long-standing diabetic patient who's never been controlled before and suddenly the kidney, the sugar gets more and more easier to control, and if you've not been checking your renal function regularly, you better start checking your renal function because it could be onset of renal failure.
Very sad, yes.
Okay, question number 2. How do we choose among the SGLT2 inhibitors that are available in the market? Oh, this one, as Professor Chan better answer. I dare not answer.
That's a very commonly asked question, Lawrence. A very difficult to answer. Most of the guidelines will say follow where the outcome studies have shown the evidence, and that makes sense. So if you are following the evidence, then the ones that have had the cardiovascular outcomes that were positive, you should follow those. And that's what the guidelines have said. Choose the ones with CV outcome, positive outcomes. The way I look at it, Lawrence, is more pragmatic in the sense that if my patient comes to me and says, look, doc, you told me blah, 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 wonderful drug, miracle drug, I cannot afford it. So in that circumstance, I believe that if the patient can afford an affordable SGLT2, I'd rather have a patient take the affordable SGLT2, affordable on cost, rather than not SGLT2. Yes. Because I think the evidence is so incredible. And I've shown you again in that table in my talk that they have actually put all the meta-analysis of cardiovascular outcome trials and said, look, they're all just slightly different from each other. They all, at the end of the day, give you cardiovascular benefit. Does that make sense?
Yes, absolutely. Absolutely. Guidelines are such, they are just guidelines, and we still have to, at the cold face, we have to make certain decisions. Yeah. So, Next question. Do cardiologists still see a role for DPP-4? Well, for sure. You know, no patient is just a diabetes patient, or no patient is just a diabetes patient with heart failure. So we still, and we also have elderly patients. And in a lot of elderly patients, I think the again, as Professor Chan has said, HbA1c is a huge part of the equation that we should still try to reach. It might even come down one day to a similar thing as the LDL cholesterol, right? There's LDL, an agent that reduces LDL cholesterol and shown to reduce a CRP. Is that a better agent, or is it a pure LDL story? This is still evolving. In the past, one of the problems in the past was we never got HbA1c down. We hardly got HbA1c down to that level, and now we are getting down to those levels. So yes, there is definitely a role for DPP-4.
And if I can add, Lawrence.
Yes, of course, yeah.
I, as a diabetologist, endocrinologist, are so happy that cardiologists are starting to treat diabetes. And the reason why you are comfortable with treating the diabetes is because it gives you that additional cardiovascular benefit, but these drugs are safe.
Yes.
In the sense that it doesn't cause the hypoglycemia that everybody is frightened about. And so you are comfortable about adding it before they come to see
Oh, that's because we can't get the appointment with you, that's all. We can never get the appointment. So no, but these agents are so exciting, and it's actually absolutely true. We can put them on, we are not worried about this and that side effects. We know the side effects, there are side effects, but we know what they are, and the benefits are so huge, we feel we can't wait. You know, the use of SGLT2 in the world of cardiology is actually skyrocketing. I can see some very happy industry people behind the camera. Now, next question. Can we say SGLT2 shows a class effect as the CV death result did not replicate in the Emperor trial? Maybe, SP, you are good at your trial results. Can you let us know what you think?
Almost certainly true. Where heart failure is concerned, you can see every single cardiovascular outcome trial, even though it was not what they call a cardiovascular heart failure dedicated trial, saw the same percentage of heart failure reduction. And then you see it in the heart failure dedicated trials that have completed, again, very similar percentage of heart failure reduction. Similarly, I'm sure Jeyabalan will have the same commentary on renal outcomes and renal benefit. Jeyabalan, what do you think about class effect on SGLT2 and renal outcomes?
Yeah, so I think again, if you see, if you look at EMPA-REG, the DAPA, and even the Credence, they were all looking at patients with a different spectrum of CKDs. There's a difference in proteinuria, renal functions, but they seem to work in every single class of renal impairment, from no proteinuria down to the heavy proteinurias, low GFRs to higher GFRs, with different classes of drugs. So again, I think generally it's, most drugs we all believe to be a class effect.
If I can add on to that, we know the mechanism by which the renal protection happens. You've gone through that. Even Lawrence knows about the sodium reabsorption story. You know, cardiologists talking about kidney, you know. Wow, la way. Okay, and then
about the nephron, you know.
and then we also know how the heart failure story happens in terms of the way it works. So mechanistically, we know how it works. What we don't know currently is how the cardiovascular benefit happens with SGLT2s. All right? With SGLT2s, because the cardiovascular benefit happens so quick and so early, within 2 weeks of initiating the drug, that we know for a fact that certainly the initial protection cannot be how would I say, due to the improvement in glycemic control. It has to do with volume, it has to do with maybe reduction, as you showed in your final slide, sympatho-adrenal activation, and again, some analysis after these cardiovascular outcome trials were done showed that in fact hematocrit increase actually predicted cardiovascular outcomes. So that must be something to do with the vascular volume shifts that happen to give rise to that cardiovascular benefit. And again, for the SGLT2 class, we recognize, the diabetologist recognizes that it is beyond improving glucose control. For the GLP-1, slightly different story. The GLP-1, probably a significant proportion of the cardiovascular benefit is mediated by A1C reduction because their improvement came later, about 1.5 to 2 years later. So again, we think that the A1C story was a bit more strong for the GLP-1 effect on MACE benefits. Having said that, it only explains a percentage of the cardiovascular benefits and therefore must be something beyond which they are, the scientists and all the smart people are studying. All right? So does that help?
Oh, definitely. So we have quite a number of questions. So we want to ask Jeyabalan this question. We might have to paraphrase this. Do you recommend combination therapy for renal patients? Will it cause any contraindication? So I guess something we talked about just now. So maybe we can say that, is it correct to say that in the patients on dialysis, we predominantly will be using insulin? But what about before dialysis, like say patients with lower GFR? Yeah. What would be your approach there?
Yeah, so I presume combination therapy for diabetic.
Or just what would your treatment, how would you approach diabetes treatment in a lot of these patients? Patients with a borderline creatinine between 100 to 200, 130 to 200, for example.
Okay, so first of all, I think you look at what you can use and what you can't use.
Yes.
Okay,
Yes.
So the EGFR says, but anything but stage 3 and better, generally most of the drugs can be used. So then you really don't have any issues with what you can't use. Then you got to see what else are the comorbidities of this patient. If the patient has got cardiac disease, non-cardiac disease, etc. So most of these patients are going to have cardiac disease. Most of these patients already have renal disease. So obviously the SGLTs are going to be probably be used somewhere along the line in this kind of patients. But like Prof said, we always still start with metformin as our baseline drug. So the metformin will start first and then you get added on. Nowadays, most likely in the renal setting, quite being very similar to a cardiovascular setting, the SGLTs will probably, if the patient could afford it and there's no contraindications, it probably will be number 2 in most settings, I would imagine. Okay, and then depending on the sugar control, then you add on the other stuff.
Right.
I think perhaps further along from that is that there may be the SGLT2s, as far as I know from the trials that were recently published, the Credence trial and then the DAPA CKD trial that were dedicated kidney trials. They started from an EGFR of 25 recruitment, and then they allowed these individuals who were recruited into these trials to go on, they leave them on active drug until dialysis, until they reach dialysis. Once they reach dialysis, they stop the SGLT2. So the answer is, don't start an SGLT2 if the patient is below 25 because there's not much data there. But if you are starting above, let's say starting at 30, 40, 45, and the patient eventually will progress, then the question is, when do I stop? The trials did not stop, even when they dipped below the recruitment baseline. They allowed them to continue until they were on dialysis. But on dialysis, they stopped. That was the trial, what they did.
Okay, this one is a provocative question. Should we avoid insulin in diabetics with a high cardiovascular risk?
That's your problem, Lawrence. Drug X, Choi. All right. So please delete from memory what he showed. Right.
Let me tell you, number one, your patients are going to avoid insulin anyway.
Die standing lah, you know. They
avoid.
already got all the bad misconceptions and all the.
And this will add to it.
Lawrence, you have added to it.
Add to it.
You know. I say.
Okay.
So what's happened is these observational meta-analyses are on patients who have initiated on insulin. And you know from what Jeyabalan just told you, right? When a patient got renal failure already, they are on insulin. And the diabetic kidney disease with renal failure, die one. Okay, so how not to die? So your risk and rates of death is going to be higher in patients who are likely to be on insulin, right? So that is the old grandmother's tale that all the patients all scared to start insulin. Wow, doctor, once I start insulin, die one. Why? Because my grandfather, after amputating the dose, start on insulin, die. The patient went on sepsis, went on insulin, die. So that's the misconception. Because insulin is always started at the late stages. So please delete from memory. Insulin does not cause excess death. If the patient requires insulin because they are at the tail end of their diabetes life where the beta cell bankrupt, pancreas bankrupt, you have no choice but to initiate insulin. I tell you, if you have a patient who is thin, who's got beta cell defect and bankrupt pancreatic islet cell, you start SGLT2, the patient will come in with DKA. Don't play the fool. So if there are patients who are not really SGLT2 type patients, don't start. All right? Please don't. Lawrence, if I get a DKA because of your talk, I send to you.
You'll be sending to me.
Yeah. Then I'll call Jeyabalan. Okay, this one was alluding to your talk earlier, SB. Elderly patient with more than 70 years old, suitable to start directly on Staglujan?
Yeah. So you're talking about the combination DPP-4 and SGLT2 Staglujan, which is SITA plus ER2, all right?
Okay.
We don't usually use age as the cutoff point for whether these drugs can be used. I think a lot of my geriatric colleagues will probably agree with that. 70 years old can be young or physiologically, and what you all call anatomically, whatever, physiological age versus cardiac age or whatever you call it, right? So if you are a decrepit 70, maybe you might not want to start on SGLT2. But for certain, the DPP-4 is safe in a patient who are unwell. But if you've got a very good 70-year-old who climbs mountains, who is more fit than you and I, and needs improving the A1C, I don't see any reason why they cannot use a combination SGLT2 and DPP-4, like Staglujan.
Yes. So this is a thing about the many questions here asking about combinations, including, is it possible to use a combination of a GLP with a DPP-4 and sulfonylureas?
Very good question. Okay, GLP-1 and DPP-4 belong to the same incretin class. One is a tablet, one is an injection. Please do not combine. Do not combine because it does not work. Because you can't stimulate the incretin class multifold. Don't be so kiasu, it doesn't work. Actually, in fact, there was a trial to actually combine the DPP-4 and do a GLP-1 combination. It didn't make any difference. So once you think a GLP-1 injection is where you want to go because GLP-1s are more powerful than DPP-4s, right? Then stop the DPP-4 and give the GLP-1, okay?
Okay.
But can you use DPP-4 with sulfonylurea? 100%. Can you use GLP-1 with sulfonylurea? 100% can.
Okay, thank you for that, Prof Chan. I also want our producers to let us know how much time we have left because the clock keeps changing. Yes, so we still have some time to have discussion. So this one, a question about this, maybe this question goes together and I can put it to both Jaya and Professor Chan. can diabetes be reversed without taking medicine? And which is the most suitable diet for a diabetic patient to lose weight? The keto diet or intermittent fasting? This is a loaded one. So, Jaya, what do you think? Can you reverse? Well, we go through. Why don't you let us know first?
Okay.
Can diabetes actually be reversed? Maybe at the early stage? I guess.
Type 2 diabetic,
yes.
right?
Type
So
2, yes.
My take as a non-endocrinologist is here, so I'll be very careful. Yeah. Okay, I think it depends what you mean by diabetic, okay? Because there's a genetic component and there's the other lifestyle component. So genetically, as a diabetic, you will remain a diabetic for the rest of your life, as far as I understand. Okay? But I think if you're talking of diabetes in terms of sugar, sugar control and stuff, and when you say reverse, mean not having to take medications, I think that can be done because intensive lifestyle control, weight control, dietary control, the sugar can then normalize and then you may have sort of reversed your diabetes, but you still remain a diabetic nevertheless because the moment you lose control of the diet, you lose a thing, you become diabetic again.
So you don't think the turmeric powder will help?
No, I don't think anything of those things work. So yeah,
The diet that you would, what between these two for weight loss, the keto diet or intermittent fasting? Any thoughts on that?
I'm not very familiar with the keto diet. I know the intermittent fasting. Some people have lost weight with intermittent fasting, but then eventually they seem to just plateau off after a while. So it seemed to work for a while for the initial part. People get so excited about this intermittent fasting, but then you always hit this bump and then that's it, So
yes.
yeah, so
from my point of view, the keto diet, as some people apply it, where they take fat to suppress their appetite, it does have an impact on their lipids. And in terms of intermittent fasting, the danger is when patients are actually on medications. So if they are not on medications, basically intermittent fasting results in about 200 less calories per day. But if you are on medicine, being a diabetic, you fail to, the regulatory systems have failed. Therefore, you may run into some problems. So it is something you really must discuss with your physician and with your dietitian. So mainly diabetes, once diagnosed, it's there already, SB?
Okay, any diet works as long as you eat less and exercise more. So keto diet, whatever diet, Ornish diet, which everybody all forgotten, all right? Any diet, as long as you lower the amount of calories that you take, will give rise to weight loss. And weight loss will give rise to improvement in glucose control. There has been a very well published and publicized study from Scotland where they put patients on meal replacements. And they only eat meal replacements. They went on for about 5 months. Meal replacements down to a very low calorie diet of 800 calories, the direct trial. And these patients lost 10 to 15 kilograms of body weight from a high baseline body weight. So they have to be big in the first place. Then when they lost this amount of weight over a 6-month period, in medical terms, we call it diabetes in remission. It's not cured, all right, as Jeyabalan has rightly said. So that in remission, what we define as in remission, no need medicine to control. And then the A1C remains excellent, all right? So, but as Jeyabalan says correctly, once you put the foot off the pedal and you're off your meal replacement and you go back to eating whenever you see food, mampus. Your weight comes back up, and most of the time, let me tell you, physiologically, your body is primed to regain that weight.
Yeah.
And when you regain that weight and gain even more, diabetes comes back. So you can put it into remission, but you have to be, in a way, big size in the first place. If you are diabetic from the genetic background, like Jeyabalan says, right, but you are skinny and the BMI is like 20, don't try and lose weight because that will not work for you. So it depends on the phenotype of the patient. Big, lose weight, yes. Skinny, lose weight, won't work.
Just with regard to that, how important is weight nowadays? Is weight the most important thing is weight a very important thing in the field of diabetes, or can you have the healthy obese patient?
Good question. I think weight for diabetes is still essential. So that unfortunately, human beings being human beings, if you love to eat, live to eat, that kind of thing, then unfortunately, no matter what lifestyle we advise patients, it doesn't work. So it's not effective. So if they don't lose weight and they don't improve their lifestyle, diabetes is not controlled, and therefore we depend on medications to get them under control. All right? What was you asked second?
Well, can you be a healthy diabetic?
Can you have a healthy obese person? We used to have a phrase that we call metabolically fit obese, but eventually they realized that this metabolically fit obese patient who is not diabetic, who is not hypertensive, who doesn't have what appears to be cardiovascular disease, still have intermediate risk of cardiovascular disease and not really as healthy as a slimmer normal body mass index.
So with that, then, that leads on to the next question from me is that, what do you think of high-dose semaglutide for weight loss? Where do you think the role would be, which we will find out in the not-too-distant future from, I mean, there's already a trial, but what do you think, what's your take on it?
I think where any trials requiring or using pharmacologic agents for weight reduction, you must remember what those trial patients were. Those trial patients were metabolically unhealthy. So not just simple and fat people. They had to have metabolic syndrome. They had to have possibly pre-diabetes, meaning intermediate phase of glucose tolerance between normal and diabetic. Only then they are allowed to test this drug out. Otherwise, what's the point, isn't it? So I would choose a patient who is, just waiting to kena one, where father, mother diabetic, brother, sister all diabetic, they're the only one not diabetic, but you do a glucose tolerance kind of like in between. This patient, I would try very hard to get the patient to lose weight because you stop the progression to frank diabetes and perhaps give them better quality of life and not having complications. So pharmacologic agents for weight loss work, and the GLP-1s are the most powerful ones that we have available. Of all the ones we have very consistent data to show weight reduction. But again, when you put the foot off the pedal, chances are they will gain the weight again.
We have probably one more question which we'll give to you, SB. And it relates to what you just said. It says that diabetic and obese patients want to try to lose weight, but they frequently comment that they feel hunger and hypoglycemia if they try to control their diet. What is your advice?
First of all, find out whether you're on any drug that might be actually exacerbating the hunger. Unfortunately, sulfonylureas do exacerbate hunger. Unfortunately, insulin does exacerbate hunger. But above and beyond that, all the other drugs that we've been talking about, metformin, DPP-4s, SGLT2s, they don't stimulate hunger. Having said that, I'm sure you yourself have seen patients where they come and tell you metformin makes them very hungry. Very difficult to explain. There are patients who feel hunger with these drugs, but I can only just reassure them, look, don't worry, your hunger will not cause you to Peng. Your sugar will not drop to a level where we are concerned that you are likely to be at risk of fainting. All right? So I think the hunger pangs may be, again, something more psychological, and you need to perhaps work on that in terms of psychological support to reduce the intake, the Malaysian seafood diet paradigm.
Well, thank you, SP. I think we are now drawing to a close. I want to thank the audience, of course, and I have to thank Professor SP Chan and Dr. Jeyabalan, who did so much of preparation for this talk. I want to thank MSD for helping sponsor this event. And I want to send a happy birthday wish to my colleagues and friends out at CVSKL on this, their 4th birthday today. And with that, we draw to a close. And thank you, everyone. And as usual, keep safe in our still difficult times. And hopefully, we will be coming out of this in the not too distant future. Thank you once again for joining us. Maybe we might have another session again. I hope to see you then. Thank you.